So BXCL701 is an oral drug that inhibits multiple targets. So it inhibits dipeptyl peptidases 4, 8, and 9, and also fibroblast activation protein, or FAP. So it hits sort of two mechanisms of action. One is it induces the inflammasome through CXCL9 and 10, which leads to an influx of NK and T cells. But through the fibroblast activation protein and other mechanisms, it also disrupts the dense desmoplastic stroma as well, which also allows more immune cells to get to the tumor. Yeah, so this research is based off my boss's boss, our cancer center director, Lou Wiener's research. He's also a GI medical oncologist like myself, but also runs our cancer center, also runs a lab. And he really showed in mouse models of pancreatic cancer that these two drugs synergize by giving an anti-PD-1 drug and the BXCL701, that by themselves there's very limited efficacy, but together there's a synergistic efficacy. And he also showed that this needs both not only T cells present, but also NK cells. And if neither are present, it doesn't work. And the cool thing is in mouse models, when the tumor is melted away, when they re-challenged the mice with the same tumor, the tumors were not able to grow, implying that there's some immunological memory that was induced by the combination. Right, so it's still quite early. We have 6 patients we presented on the poster, 3 of whom had rapid CA19-9 decline even after one cycle of pembrolizumab given with BXCL701. One patient turned out to be microsatellite instability high, which is quite rare. It's only about 1%, but she had a dramatic response and has a partial response. There's another patient who's had prolonged stable disease who has microsatellite stable disease, and he is now, just recently, not updated on the poster, also has a partial response. So out of 6 patients, we had 2 who are partial responders in a tumor type where no patients really should technically respond to immune therapy. So we're very excited about these early findings, both on the CA19-9 side and also in the objective radiographic responses. Right, so we're doing a lot of correlative science, much of which is not ready for prime time, but we did see some early signs where the patients who had a rapid CA19-9 decline also seemed to have an influx of CD8 positive T cells in the tumor and microenvironment. So it really implies that it's really the immune system that's causing this drop in CA19-9, so it sort of supports our hypothesis. So we've completed our 6 patient safety evaluation, so now the enrollment is wide open. So we're trying to accrue quite quickly and rapidly, and we're getting a lot of interest from docs, but also from patients who are very interested in a non-chemo immunotherapy-based approach. So our endpoint is an efficacy endpoint. We're trying to have patients be at least disease-free or tumors shrunk at 18 weeks by the second scan. And so if we have 7 out of the first 19 who meet that goal, then we expand the study for a total of 43 patients. So far we have 2 out of the first 7 that are disease-free or better at 18 weeks. So we think we're on target to achieve that Simon 2-stage goal.